Good morning, everybody, and it's really a pleasure to be here. I'm honored to speak after my Dean for Academic Affairs, and of course, heartened by the remarks from the Minister of Health and the acknowledgement of the importance of adolescent health for Tanzania and for the region. Thanks to the remarks of the US Ambassador as well, and for your continued support. So I will cover briefly, if I could have the slides, on behalf of my colleagues, sort of the latest that we have been advancing around research training and our vision for next steps in this area as part of our ARISE network. As the slides come, one could sort of recognize the size of adolescents in Africa, in Tanzania. This is not the slide. If I could have the slides with my presentation, I'd be grateful. Yes, that's wonderful. Adolescents, typically 10 to 19 years of age, sometimes we talk about adolescents and young people, 10 to 24, are sort of large numbers in many settings. 9 out of 10 adolescents live in low and middle income countries, particularly in Africa. Africa is a young continent. About 70% of the population in Africa are under the age of 30. That really provides a major opportunity. It's sometimes referred to as a demographic dividend, where one has millions of future leaders who are likely to take on many of the challenges on the continent. But in order for them to succeed, we have to focus on aspects of their health and their nutrition today. The focus of the ARISE network has been to document the state of adolescent health and identify solutions that are able to address these challenges. This is a slide of our ARISE network, particularly focusing on the African partners. Many of them are here in 9 countries that Mary has mentioned earlier, with an aspiration of a 10th country that's coming on board, Senegal. Delighted that colleagues from Senegal are joining us this year, and we are excited about their engagement, and we will learn from them as much as I'm sure they will have an opportunity to learn from the partners of the network. The ARISE network really has 3 pillars of focus. One aspect is research, the development of new knowledge, documenting problems and finding solutions. A second pillar around building capacity, training of adolescents, training of researchers, partnerships of academic institutions. And a third pillar really that the Minister has emphasized, sort of the evidence to practice aspect. We're quite keen on engaging with policymakers at regional level, at local government, at federal level, and indeed at continental level to advance some of the findings into actual practice. Briefly, what I'll try to cover today are 3 buckets of activities. A group of work that we have been pursuing around systematic reviews, the top. A group of studies that we call observational studies, where we just document the issues and the concerns, and really moving forward to intervention studies has been something that we are particularly keen on. In the area of systematic reviews, this is essentially documenting the state of the evidence, reviewing the literature, building on what has been known already rather than sort of recreating the same facts. So it was critical that we examine the experience in many countries in Africa, in Asia, in Latin America, in the US, and learn from those experiences as far as the role of school feeding programs, how school gardens are put in place, how various interventions are put together in other settings. In the observational set of studies, essentially we take stock of the state of health, what are the risk factors, what are the problems, what are the conditions, and do that in community settings as well as in school-based contexts. And I'll speak briefly about these three elements in my next 3 slides. And then the last aspect that I'll touch on is around interventions. We have been delivering a number of interventions and are working together to scale that up further. So in terms of observational studies, the first set of studies that we have done as a network was this community-based adolescent health study, where we engaged with partners in the ARISE network, essentially members of universities around Africa who have also strong bases in their own communities in Nigeria, in Uganda, in Ethiopia, in Tanzania, and in other settings, where we have done a cross-sectional survey among more than 8,000 adolescents who are 10 to 19 years of age in 9 communities that were based in 7 countries. Essentially, we did that within the context of the health and demographic surveillance systems in those countries. We do a random sample of adolescents and examine the outcomes. This set of surveys were put together as analysis that were published as a special issue in the journal Tropical Medicine and International Health, as you can see on the screen. And some of the key findings, if I could just highlight a couple of them. Undernutrition remains a big problem. Wasting and stunting among adolescents are significant challenges among adolescents in the various sub-Saharan African countries. But so is the rising tide of overweight and obesity, as we have heard. There continues to be this double burden of malnutrition that is quite prevalent. A second key observation was diet was poor in many settings. There is sort of always a variability. There is a range of conditions, but on average, there is a lot that can be done to address better access to fruits and vegetables, and a better way of controlling and reducing access, if possible, to sodas and sugar-sweetened beverages that are contributing to the overweight and obesity. Another key finding from our surveys among adolescents is that mental health, as we have heard, are important challenges. Anxiety and depression are particularly important to note. Our second survey was focusing more intently on young adolescents. Instead of the broad 10 to 19 or 10 to 24, there is much less that's known about 10 to 14 years of age. And so we have engaged with partners in the ARISE network in 5 urban centers to examine the same set of issues, but among urban populations, among young adolescents in those settings. And some of the key findings have been anemia is a problem in all settings. In many settings, it is more than 50% of adolescents are anemic. But in that same study, in the context of schools, we have strived to understand the school environment. We see really a partnership between the health sector and the education sector as instrumental in advancing the health of adolescents. And so having schools as a platform, not only for education, but also for provision of health and nutrition in a way that advances both the educational performance as well as the health of students is instrumental. So beyond the health of adolescents, we looked at the school environment and variability in the various centers, but many challenges with the facilities at the school that serve the students in terms of canteens that offer food, toilet facilities, hand washing stations are limited in many settings and wanting really for significant investments. Places for changing room for girls has been a challenge, and access to menstrual hygiene services and sanitary pads is a challenge. And finally, looking at the physical environment in many schools, the infrastructure to enable physical activity is quite short. So finding ways to enhance that would be important in addressing the rising tide of overweight and obesity. A third component that we've done in this study is really to engage with vendors, vendors around the school who serve the students, who serve typically unhealthy diets. and working with them to understand from their perspective what are the challenges they face and how can they be part of the solution. These studies are put together also as a special issue that is upcoming in the journal Maternal and Child Nutrition in the next month or so. And we use these various surveys really as elements for capacity building. So the various studies and papers are led by junior scientists in Africa, in Tanzania, in Nigeria, in Uganda, with partnership of senior colleagues in these countries, as well as partners at Harvard and Heidelberg and other partners. And the third observational study that is just at the last part of it was focusing on sort of moving from a snapshot assessment to a longitudinal assessment of the state of adolescent health. So one first step was to identify a short tool, develop a tool. If you look at the first box, develop a tool really that highlights in a short way what are the key indicators that assess diet, physical activity, mental health, sexual reproductive health, and other key domains. And that has been done by bringing together experts who are in these various domains from Africa and from around the world. And the product has been published as a paper in the Lancet eClinical Medicine. And then we took that survey tool and administered it 2 times in our second bucket to assess really and be able to track these key indicators over time. This set of 2 rounds of surveys happened in 10 sites. 8 of them are in sub-Saharan Africa. We have found an opportunity also to team up with partners in India and in China to really leverage their understanding and hopefully share our experiences with them as a way to advance the global perspective that the ambassador has been looking and talking about. And finally, in the process between the 2 surveys, we have developed and tested digital methods to connect with adolescents. So we provided them with messages through SMS and social media to understand dietary quality and physical activity as a way to enhance our understanding of how we can connect with digital methods with adolescents. If I could transition to speak briefly around the intervention studies that we have done. We have a set of studies. I'll be very brief. One is MEGA, our Meals, Education and Gardens for Adolescents study, done with the University of Dodoma and with the Africa Academy of Public Health. Many colleagues are here who have been leading that effort at AAPH and at UDOM. Essentially, this was a trial, a proof of principle study in 6 schools. In 2 schools, they received a package of interventions, school meal, a midday meal. They received the school garden. They received nutrition education, which was provided through enhancement of the curriculum in class. And there was a 4th component that brought in parents and used the school garden really as a platform to enhance homestead gardening. So parents came to these community workshops to learn and take those tools back to their home. So substantive schools received the whole package. A substantive school received only 3 of the interventions, and there were 2 schools that received the standard of care. And some of the key findings that are forthcoming in a publication was essentially finding that the intervention was successful in enhancing knowledge about food and nutrition. There was, beyond knowledge, an actual practice reported increased dietary quality among adolescents and among parents. And there was an improvement in weight and BMI of these adolescents. But it was a short intervention. It was really only for 7 months. It was not a very large sample size in only 6 schools. There wasn't an impact on anemia and some of the other sort of outcomes that require longer intervention. And so we are talking with Professor Wafaie, Dr. Katalabula, colleagues at AAPH about a scale-up of that into a next phase. Our second study, what we call SAMIA, or Rutubisha Afya here in Tanzania. Essentially 2 countries, one in Burkina Faso and one in Zanzibar. Looking at 14 schools who received a weekly iron and folic acid supplement given to adolescents, 14 schools that received a daily multiple micronutrient supplement, and 14 schools that received standard of care. And briefly, some of the findings on the left in Burkina Faso and on the right in Zanzibar. In both settings, anemia is a major problem, more so among girls than boys. In Burkina Faso, in Nuna rural center, 36% of adolescents were anemic at baseline. However, when we provided these supplements, there wasn't much of an impact on anemia. Both of them did not have an impact, and we are studying the reasons for that with our partners from Burkina who are here. It could be a higher burden of malaria that exists in that setting. It could be a higher burden of parasitic infections that we have not particularly addressed. And so that's something that we are looking at more carefully. In Zanzibar, we did the same study, and the results are really being analyzed, but just to share some preliminary findings today, there was no effect of iron folic acid given weekly, but there was a significant improvement in anemia by provision of daily multi-micronutrient supplements to adolescents. So about a 36% reduction in the risk of moderate to severe anemia in those adolescents. The next set of efforts really is to move beyond sort of only supplements or only food interventions to come up with really a holistic intervention, an integrated approach. So we are advancing a study focusing here in Dar es Salaam on designing a whole school intervention program and really engaging with adolescents. We were visiting yesterday at Salma Kikwete Secondary School, also engaging with Turiani Secondary School here in Dar es Salaam, and really with adolescents, with the parents, with the vendors, with the headmasters, with the teachers, to come up with a human-centered design approach that comes up with what is a realistic intervention that is likely to succeed. So we've been through these steps. We developed a prototype package of intervention and are about to launch that in partnership with the schools. And last but not least, 2 exciting initiatives that are underway for the ARISE network. ARISE Nutrient on top, in the green, the dash. These are 2 projects with support from German partners in partnership with African institutions and Harvard. Exciting to see the network expanding thanks to the leadership of Professor Till Barnighausen and the team from our partner institutions in Europe. Essentially, both of them have an element of surveillance where we are doing annual rounds of assessment of the health of nutrition and other health indicators in adolescents, but also working on 3 interventions: nutrition interventions, mental health, and sexual and reproductive health. And we have had some meetings in the last couple of days and more meetings tomorrow and Monday and Tuesday, really to focus more intently on these coming efforts. And my last slide really is to sort of think about, for us, what are the key considerations for adolescent health, and we have noted 5 of them here. First is to understand the extent of the problem. 2, to develop solutions that are innovative and done with adolescents, engaging them. 3, to move beyond just doing the research, but really scaling it up to have effective interventions. 4, to embed in it a significant portion of capacity building so that we grow as a community and learn and lead. And last, really, do that with multiple stakeholders and not in siloed domains, engaging different ministries, engaging policymakers as well as other stakeholders that are critical for the success of our efforts. I am grateful for the partnership that we have, all the institutions that are part of this effort. Many of them are listed here, and many donors who have been instrumental in enabling our work. Thank you so much for listening.